So I do know each of you personally. I know Jay for many years now. We've been on the Performance Health Education Committee together. And Jay is in practice in Washington, D.C., the owner of 5 chiropractic offices that have integrated physical therapy and rehab into his practices. He's the CEO, the Chief Executive Officer of Kaizo Health. And Jay is probably one of the most creative thinkers in our profession at this time. I am really looking forward to hearing some of your answers personally. And Dr. Fowler and I go way back, being part of the Rehab Association. And some of you may know him as the tester. He was probably one of the people that tested you to achieve your diplomate status. And Dr. Fowler has been in practice for over 32 years in private practice, and then he left that to be a part of a big rehab organization, which we'll hear about today. And I know Jeff, meeting him at a Parker seminar a few years ago, and he knew that I was into rehab, and we were talking. He was a diplomate at that time as well. And he was telling me about his practice. He has a large practice, and it is an integrative practice, and that is the theme. This theme was brought about by me talking to Jay and to Tom about the integrative health concepts, the actual revolution of healthcare delivery. And it's a segue to what I hope happens in 2020. That my vision for 2020 is that we have a symposium where we have integrative healthcare practitioners talking to us about the latest trends and what else can we integrate into chiropractic care. So again, welcome. And the way I'd like to start this off is asking you if each one of you could just tell us about your current business and what makes what you do different. So, Jeff, would you like to start?
Sure. I'm Jeff Dickhut, and I practice in Bloomington Normal, Illinois. And I graduated from Palmer in 2002 and started off with a great set of hands and not much business acumen or any understanding of billing or anything like that. I was wanting to change the world with adjustments coming out of Palmer. I worked with another doc for about a year, and then I opened up my own practice, and it was myself, and I had a college student. I wouldn't say an actual CA, but a college student that answered the phones and did those things. And then we grew over the years, added rehab. It was low tech to start with, added lots of equipment, and now we're at the point where I have about 22 staff. I have 2 doctors of chiropractic that I have absorbed their clinics into my clinic. And we've got a doctor of physical therapy, 3 PTAs, and a pain management doctor. And the thing is that we're still at the core. I think like a chiropractor. I want to see their function change. I want to see their structure change. And these other things have become tools to help get those outcomes.
Great. Dr. Fowler, can you tell us about your current business?
Current or past? Or both?
Both.
All right.
Sure.
I graduated from Palmer in 1986. I started taking the rehab courses with Kim Christensen. Gosh, it was probably 1991 in Chicago. I got my diplomate in, I believe, 95. I was the 7th diplomate that we had. Started on the board shortly after that and have been on board since. Had a practice in Holland, Michigan, where I practiced for approximately 32 years. Michigan was not always the best place to practice there for a while. And when I got there, I went in and started treating workers' compensation patients. So we started by setting up on-site clinics. We had MDs, PTs, nurses. We had on-site clinics at several large industries where we would treat people at their facilities. We started to do a lot of wellness programs at the facilities. I continued to do that for many years. I started working with one of our larger insurance companies in Michigan called Priority Health. We helped them establish spinal centers of excellence. And it was originally designed to have chiropractic, PT, PM&R, physiatrists, and then have the ability to evaluate patients, treat patients, utilize injection therapy appropriately so it wasn't being misused. and then start to compare outcomes. And unfortunately, the neurosurgeons caught wind of all this, and it kind of got watered down to where the, where the primary health required the patient to see a physiatrist before they saw a surgeon. And that still reduced their cost by almost $16 million. And they were published in Spine for this whole program. But if they really would have done it right, I think they could have really caused some significant change. From that piece, I was approached about 2.5 years ago by a hospital group. It's a rehab hospital. I think it's the 4th or 5th largest rehab hospital in the country. And they talked to me about spine centers and setting up spine centers of excellence. So I started to work for, it's called Mary Free Bed. It's in Grand Rapids, Michigan. And started working for them about 2 years ago. And went from setting up spinal centers to directing their outpatient services to now setting up all their businesses throughout the state. So I'm a director of business development and outpatient services, and I manage about 400 different PTs, which is kind of fun. So that's kind of where I'm at currently.
That's good. Cool. Jay?
Yeah, so as Jeff told you guys, we have 5 chiropractic rehab practices in the DC area. We have 4 divisions of our company. So the first division is the practices. Second division is our wellness division, where we do evidence-based rehab to wellness performance training. So it's sports performance, it's personal training, all the wellness services that are non-covered services by insurance, but definitely important to the patients that we serve. The third division of our company is a 501c3 clinical research foundation. So we run clinical trials in our practices. We've got our own IRB, that stands for Institutional Review Board. In order to publish human subject trials, you need to have an IRB to approve the actual study for patient safety reasons. We had that approved by Department of Health and Human Services in 2011, I believe, 2010, 2011. So research has always been near and dear to my heart. Any national grads out there? Cool, so you guys remember Greg Kramer? So I started in a spinal morphometry lab, which was like in the dungeon of that building and dissecting IVFs. It was so much fun. But yeah, so research has always been near and dear to my heart, and I think it's become so important to our profession to be able to publish the outcomes that we get. And then the last division of our company, which is probably even more exciting than the research piece, is the technology division. So we're starting to build technology that we know will impact population health at scale. And so we've created a spine technology. We are also rolling out a private practice app technology for other healthcare providers. And you know, it's just, we live in a world of like immense change, exponential change, and I'll be talking about this on Sunday again, but we really feel like we want to leverage those technological tools to advance the profession, but also to advance patient care.
So Tom, I'm curious, what was the process for you to get into the current business model? Did you close shop and then go into this? What was that transition?
Yeah, essentially I had an associate that was working with me who was just building his own practice within my practice. And when they asked me to join Mary Free Bed, I tried to transition a little bit. I thought, well, I'll still see patients at the practice and then work for Mary Free Bed. That lasted about 6 weeks, and I decided that that probably wasn't going to be really what I needed to do. And my job at Free Bed became much more than what we anticipated. So then I basically just allowed the chiropractor that was with me to start taking over patients he's currently buying out of my practice.
Okay. And so what's your day-to-day like now?
I don't use my hands as much, which sometimes is a little easier. I've had 8 trigger finger releases and 2 carpal tunnel surgeries, so that's kind of a blessing for me.
Yeah.
And I get every morning I'm up at 5 o'clock in the morning. I'm usually answering emails at 6. I go to work. I travel much more now. If anyone's familiar with Michigan, I'm traveling to Traverse City frequently. I'm over in Detroit and Saginaw. We've done some hospital acquisitions. Mary Free Bed is really partner-minded, so we partner, and all we do is rehab. We have 35 PM&R docs that work for us, and what we do is we manage inpatient rehab and outpatient rehab. I'm just an outpatient, but we just formed a joint venture with Munson Healthcare Systems, which is a 10-hospital system in northern Michigan. We just formed another joint venture with Covenant in Saginaw, and we have kind of some unique programs that we do. We have a lot of interdisciplinary programs where we have spine. We have a chronic behavioral pain program that treats chronic pain, and it's done with heavy in psychology, acceptance, and commitment therapies. OT and PT to help the deconditioning aspect of it. And it's run by a family physician that simply, he just weans people off of their opioids if they're on opioids. He doesn't use Suboxone or anything else. It's a program that we had on campus for about 35 years with really good outcomes. And now whenever we go to these other hospital systems, that's one of the programs that we set up because it's very successful.
Good.
Yeah.
All right. And so Jay, let's dive a little deeper.
Okay.
So what are some of the challenges that you see that we're facing?
And the biggest and most obvious changes for us at least, is really the insurance and the third-party payment system that we're in. I spent a lot of my time doing policy and advocacy work on behalf of the profession, and I just see a lot of challenges. We're faced with a lot of challenges if we're dealing inside the third-party reimbursement arena. It's really interesting. I don't know if anybody saw the Dave Elton video. He was presenting at some conference. He's, by the way, the SVP at Optum, and Optum has phenomenal analytics. And he's talking about the importance of chiropractic as it relates to spine care delivery. And he's going through all the data, and you might have seen some of the previous data that if you enter the chiropractic portal of entry, you save the system billions of dollars, and that's all great. And at the same time, they're moving more patients potentially into our offices, but not necessarily wanting to pay us more. They're capping us at a per diem, and there's other third-party administrators out there like Evacor and ASH and all those fun acronyms and organizations that just create a lot of downward pressure for providers. So for docs that have other provider types like MDs or PTs, it may be a little bit easier. But it's interesting because I was in a physiatry office, a group called Stem Cell Arts, which is an offshoot of National Spine and Pain. And they were talking about the downward price pressure too. They're struggling. They're dealing with consolidation in hospitals, gobbling up clinics, and all of that. So third-party payer issues are significant. And I've said it a lot. It takes an army. And some of our best evidence, quite frankly, some of our best ammunition is the evidence. And I think as we move forward, it's going to be big data that's actually going to be our best weapon against these injustices.
Okay. And so I have another question for you that I want to hear right away, which is what do you think are some of the trends?
I think consolidation is going to continue. I mean, you're going to see larger organizations like Aetna and CVS. I mean, those types of consolidations creating vertical integration. All of that is going to create profits for big business, and it's going to create a lot of continued downward price pressure on providers. And again, I don't think it's just chiropractic. I think it's across the spectrum, but we certainly get kicked around like the stinky neighborhood dog, and we just shouldn't stand for it.
So you have the 5 offices, and Jeff, you've got one with everything in it.
Correct.
So tell us, what it's like. Why should they go in a group or should they go on their own?
So everybody really needs to figure out what they want to do, set up your own goals. There's not one thing that works for everybody. And I started off and I saw other doctors that had large practices and they had time to be with their kids and things like that. And that's part of what it started with, was just wanting to be more successful and help more people. And I realized I couldn't do it all myself. Now it takes a lot of time to train people. It takes a lot of time to have them be the extension of you. But if you put the time and effort into it, you can come to a place like this, and my clinic is still running this week. And so that takes a lot of effort to get it set up that way. I'm not the only one that everybody relies on. So when patients don't get a result because maybe the adjustment, the rehab, something's not making a change, we don't have just 1 or 2 things as an option. We've always got other stuff. And we do very, very little pain management. Very little. If we do 1 or 2 cortisone injections a month, that's probably a lot. But it's nice to have that in reserve, and it's nice to almost have that. It's not a threat, but if a patient can't get through this next month, then we've always got this to do. And most of the time they talk themselves out of it, and they go with a more natural approach.
What are all the therapies available in your office?
So I've got 7 DRX machines, I've got tons of physical therapy equipment, computerized stuff. several lasers, ultrasound, vibration therapy. We've got pain management suite, so a moving X-ray as well as a video fluoroscopy unit, and
Who's the case supervisor?
So I'm like the head doctor. You know, I own the practice and I consult with all the patients, but then as we go through, I lay out a treatment plan, and then it's fulfilled by a lot of the other doctors in the clinic and the staff.
So what drove you to be more integrated?
Several things. One was that I'd lost a lot of patients to the other doctors in town. You know, patients were getting great results. I had one patient, she was in her 20s, she came in with a cane, horrible herniated discs. And several months later, with all that we were doing, she was jogging and doing great. And she asked me, I've got an appointment with the surgeon next week, should I cancel that? And I said, no. I went to school to be an engineer. It's always better to have more than one set of eyes on something. I said, no, keep it. And I thought the surgeon would have been so impressed at how we get referrals and, you know, there would be a big party. She came back the next week on a cane, and she was hunched over like Quasimodo. And I just looked at her and said, what's going on? And she said, well, I saw the surgeon. Bad news, I got to have back surgery on Friday. I'm like, on Friday? What happened? And the surgeon came in, and no exam, no new MRI, didn't touch the patient, just said, how are you doing? The patient said, you know, I'm doing a lot better than last time I saw you. And she said, what have you been doing? Well, I've been doing Dr. Dickhut's decompression, his physical therapy, chiropractic adjustments. The surgeon cut her off and said, you might be feeling better, but until we cut the discs out of your back that are pushing on the nerves, your body's never going to have a chance to heal. And sometimes I think I'm motivated more by getting ticked off about something than going to, you know, I mean, it was a driving force. But I had not one, but several patients that were like that they had great results objectively and everything else that you could see, but they got the nocebo effect from their surgeon, and it just tanked them. And so I basically set up an island where I brought other providers to me to provide those services, because the surgeons are smart. They've got the pain doctors, the radiologists, all kinds of people working for them. And it's amazing how many times I've looked at X-ray reports, and they'll say that there's an instability on a low back, and I'll look at the actual pictures, and there's no movement at all. But the surgeon knows, or I mean the radiologist works for the surgeon in the same group, and they know that Medicare pays for it if there's more than so many millimeters of slippage. So, you know, it's just, you make conclusions over time, and I think that's where, you know, we sit around and think about that type of stuff.
Yeah, for sure. Yeah. So, Tom, I mean, you're a leader, you know, in the rehab group, and I think you have a certain vision yourself of what you'd like to see the rehab chiropractic group transition into, or what direction would you like rehab docs to start transitioning into or looking like?
Yeah, I think it's really what everybody wants to do. But I think what we've really focused on, and I think what we're really good at, is musculoskeletal rehab. That is something that I think every one of us in the room is really very, very good at. But where I see the PTs kind of going ahead of us a little bit is in different aspects of rehab, you know, neural rehab, cancer rehab, diabetic rehab. We have over 110 different programs. I mean, we rehab everything. so
keep going on the list.
Yeah, so when you keep going, you know, some of the pediatric rehab, cerebral palsy, traumatic brain injury, stroke. You know, when one of those people walk into your office, you really know what you need to do as a rehab chiropractor. From a musculoskeletal standpoint, I think we all do. You know, but how many ways can you stabilize the spine? I mean, that's what I keep teasing Jeff about is, you know, here's one way to do it, here's another way. But what do you do when a traumatic brain injury walks into your office? And you know, what do you have to know about that? Because there's different things that need to be done for that population. Same for a stroke, same for, you know, we talked about cancer rehab. I mentioned cancer rehab to Jeff, and he's like, no, we don't want to go there. And I said, you know, but what about all the chemically induced peripheral neuropathies that we have? How do you treat those? Yeah. What about all the pelvic floor instabilities?
Give us the diagnosis,
absolutely.
And then we'll
get really the deconditioning that occurs with a cancer patient. You know, there's just so many sequelae of the treatment for that we should be involved in. and we should be involved in neural rehabs. We should be involved in all those. How do you treat a cerebral palsy kid that walks into your office? You know, an autistic kid. You know, what do you do with someone that has autism? We're seeing that diagnosis more and more now. So how do we get to that level where we have knowledge and skill and ability so we feel comfortable treating those people?
Do you see the PTs doing something different than what we're doing?
No, not necessarily, not at all.
Yeah.
I mean, they just have, you know, they know the different things that they need to look for.
Right.
So I don't think it would take us, there wouldn't be much of a learning curve to get us to those levels. So I would love to have speakers come in and start talking about neural rehab, stroke rehab, all the different things that we could do. I think that would bring some value to what we do. You know, we're a not-for-profit organization, so we look at value.
Yeah.
And you know, when you think of value for your customer, for your patient, whatever it might be, you know, there's a definition that we use for value, and value is outcome over cost. That's a Michael Porter thing.
Yeah.
So essentially, you know, what value are we going to bring to our customers? And I think what we have to start thinking about is what else, how can we treat people? I think we're very efficient at what we do. And I think these guys are right when you say, you know, the outcomes will prove that.
Yeah.
I don't always think we all take outcomes, but how do you track them? If you're a solo practice, it's difficult to say, how do I get all the data that I need? How do I collect it?
Yeah.
How do I disseminate it? How do I get it to my referral sources so they know what my outcomes are? Those are all things that, you know, private practice struggle with because it's costly.
And I think in this day and age,
Very costly.
the insurance companies expect it from us.
And they do.
Yeah.
And they do. I meet with insurance companies regularly. We do contracts with those companies. In the hospital, you have hospital-based billing, and that's significantly larger than what we get as private practice. What we're doing with all of our private practice clinics, and I'll call them private practice clinics, instead of doing hospital billing, we're dropping down to private practice billing. So we're actually taking less money for what we do to bring a better value to a customer. If somebody comes in for, you know, a lateral epicondylitis, and our hospital charges are applied to that, it makes no sense whatsoever. So that's not a value to our customer. So what we need to do is say we're decreasing our costs so we can compete with everyone else. Because if I was private practice, I'd say, why are you going to these guys? They're charging 4 times as much as I do. So we recognize that, and we said, you know, we have to drop those costs down so we can be more effective.
You know, you were talking yesterday about the prosthetic cases.
Prosthetic.
I think that would be a great story to tell
Yeah.
because it's so different.
We have a orthotic, prosthetic, and bionics division in our hospital, and the gentleman that hired me, he's my boss, the VP of some of the outpatient. He was telling me a story about a lady that he treated that had sepsis, and she lost all 4 of her limbs. She lost her legs and she lost her arms, and it's a month or 2 ago, probably longer, time escapes me. She came running down the hall with prosthetic legs that she could run on, bionic arms and hands and move. And it was amazing. And she gave him a big hug and a big kiss, just because she got her life back because of what our hospital did for her. It's just really a neat story. You walk through that hospital, whenever I think I'm having a bad day, I tell my wife, I just walk out into our peds department and I see these little kids, and I'm like, yeah, my day's not bad at all. And some of the struggles they go through, it's amazing. It's amazing. And anyone here is welcome at any time. Call me. I'd be happy to bring you to the hospital, show you around for a day. It's really opens your eyes to what they can do. They have exoskeletons. Anybody heard of an exoskeleton? Yeah. If you see those people walk, if they walk for the first time, just the grin on their face. It's amazing. It's amazing the stuff that they do.
Good.
It's awesome.
Good. So, Jay, if you were to go down each road, you know, separate, distinct, or integrated, what's the future look like?
I definitely think integrative.
Yeah.
You know, even though we don't have other provider types in our practices, you know, we have very, very strong working relationships with other healthcare providers in the community. And we are also very interested in referring within the chiropractic discipline. We send to chiropractic neurologists all the time. I've got a good friend who's a diplomat in internal disorders, Cindy Howard, who's a really close friend of mine. I mean, I send her patients, she's in Chicago, I'm in DC, and I send her patients seems like every week. But if they require medical attention or some other healthcare provider that's not chiropractic, I mean, we've got really strong relationships, so the patient is still getting an integrative approach. It's not in the same physical location, you know, like Jeff, but it still is the approach where the patient is at the center of care, and whatever they need and whatever's going to be best for them can be had as long as the providers are making the right clinical decisions.
It's good. This is a question for each of you. Like, what's the single biggest threat to chiropractic survival in this current healthcare system? Tom, you've got some thoughts.
Well, yeah, you know, I think there's there's a lot of things that we have to be very concerned about.
Yeah.
You know, and I think you have to make a choice sometimes how you want to practice. If you decide that you want to, you know, practice within a system, like, you know, what I'm trying to do, and we're integrating chiropractic into the hospital, at the rehab hospital, so hopefully we can make some changes there. But I think we run the risk of just really being pushed out of the reimbursement system. I think that's possible, unless we can really prove our value again. And then you can certainly survive on cash, but it's a different way, a different model, and you have to run, you know, thin and lean, and you have to make sure that you're efficient. I don't think we'll ever, you know, go away, but I think it will be a little bit tougher and tougher. I think everyone is seeing that, you know, higher deductibles, the, you know, higher co-pays, all those types of things. Those are a challenge, you know. It's just tough. I think, you know, my opinion is we need to integrate with medicine and with other disciplines, and I think if we can do that and be part of that, I think we'll be successful. I really do.
Good.
If I can just comment really quick, I speak a fair amount, and one of the presentations that I give is called the 5 Dysfunctions of Chiropractic. And people always say, like, only 5, or is like that the first of like 10 versions? Like, well, what's the story here? But it really came from a book by Patrick Lencioni called The 5 Dysfunctions of a Team. And if you've ever read that book, or if you haven't read that book and you're leading people, it's probably a pretty good book to read. But nonetheless, it's built on like Maslow's hierarchy of needs. So if you don't have like that first level of trust, then you don't have conflict, and it goes on and on for dysfunction of team. But when I thought about the chiropractic profession, and I've sat on the chiropractic summit for many years, and again, done a fair amount of policy work and advocacy work, you know, I think our biggest threat is actually lack of unity. Because without unity, we don't have strategy, and without strategy, we don't have a clear identity. Without a clear identity, we have intra-professional apathy, and with that apathy, we have a lack of results. So I think the reimbursement challenges, the legislative challenges, all these challenges that we face are really because we don't have a strong enough profession. And I think when that, and I don't say if, I say when that gets fixed, I think we'll all be better off. And I agree with Tom completely. You know, moving into that integrative model is only good for the profession, but we still, as a profession, need to be significantly stronger, and I think that starts with unity.
I was recently in Washington, D.C. at the NCLC, and I thought they did a good job. You know, I think that they're really trying to help rebrand us, so to speak. And I know, Jeff, you had some thoughts.
Yeah, well, it's interesting. When the deductibles went high, that was actually like a boom for me, because I finally felt like I had a playing field that was evened out for the first time, because patients could go to the surgeon and it would cost them $50. They could come to me, and it's going to be thousands of dollars, you know, in the past. And now all of a sudden, when the ACA kicked in, and patients had around us $10, $12, $15, $18, $20,000 deductibles, and it was interesting because the surgeons, they were not getting their fees from the patient, and they're no longer getting, you know, if they bill $20,000, they get $5,000 from insurance, and they're supposed to collect $2,000 or $3,000 from the patient. At least they got $5,000 from the insurance if the patient paid nothing. Well, now all of a sudden, if they've got a $10,000, $20,000 deductible, they do a carpal tunnel surgery, they get $0 from the insurance, they got to collect it off from the patient. So the surgeons around me actually started having like a retainer type of fee for a consult. It was like $4,000 to do a consult with them.
Oh my God.
So what I did is I looked at that as an opportunity, and I was able to say, you know what, you're going to talk to the surgeon, you know, for $4,000 or $5,000. That's probably what they're going to charge for you just to talk to them. You can get a lot of care for $4,000 or $5,000 over here. And when they call up the surgeon's office and say, you know, hey, how much is it for me to come in and talk? Well, it's $5,000, you know, and so what I was saying was true. So a lot of it is looking at your challenges and then turning them into opportunities. And so I think that the unity thing is great on one hand, but on the flip side, it's nice to have some chiropractors over here that do the really weird voodoo stuff that gets the results with that patient that doesn't respond to the traditional stuff. And we have lots of patients that come in that have been to 4 or 5 rounds of physical therapy, and then they come and they get better with us. And that's not just our clinic, I mean, that's just how it is, right? You do something a little different, and that's, if everybody does it exactly the same way, those patients won't get those chances to get better, so.
But don't confuse political unity with clinical, like this, I definitely agree with you, like, it's not about every patient getting a certain type of care. But I'm talking about the political unity, like organization within the profession. that create the strategy that then leads to results.
I think you made a good point with identity. It's interesting because as I've talked to more and more physicians, as I talk to hospital leaders in different areas, they still think, at least in Michigan, that chiropractic is manipulation. That's all they think about. So they don't think we do anything else. They think that's all they want to sit down and talk about it, because they really don't know what we do. So we don't do a real good job of educating what we do. And I think what happens, they just automatically think we do manipulation, that's all we do. When I had our CMO at the hospital when I first started working there, he goes, "Do you guys do exams?" I said, "Yeah, much better than you."
Absolutely.
And it's interesting, when I talk to a lot of the PMR docs that we have, they're really nervous about what we do. They get a little bit nervous. And as we talk about integrating into the hospital system, there's this, they don't really know what we do, and they're really kind of nervous because they know that we have a good following, we have a lot of patients, but they don't really know why.
Yeah, like what we do.
Exactly. So I think there's an identity issue. I really do. And I think Jay said that well.
Yeah, it's like I met with the medical director of Care First, this young guy, probably 10 years younger than me, and he literally had no idea what chiropractic was. I mean, he knows that chiropractic exists, but when it came to mechanisms of action or the clinical evidence around what we do, like literally not a clue. And we had to go back and like literally do a presentation and say, this is what chiropractic is, this is what evidence-based chiropractic looks like, and this is why it's beneficial. This is how chiropractors help to achieve triple aim, you know, which is the language, you talk about value, Tom, right? It's like, that's the language that they speak, and we're perfectly positioned for that.
Yeah, share the whole, triple aim concepts a little bit with the.
So triple aim is really what's more important is quadruple aim, but triple aim is better outcomes, lower cost, higher levels of patient satisfaction. But quadruple aim also incorporates provider satisfaction as well. So it's really what should be driving value-based healthcare.
I want to improve our position in the healthcare system. So what are all the opportunities, that you see that we could do that? I mean, I heard several things: identity, education, blame. What else?
I would say, like, without a doubt in my mind, it's big data. It's just big data. Like, big data is going to move the needle for us.
No, it's scary to some people when they hear that.
Yeah, it doesn't scare me. I think it's a great thing for our profession.
Okay.
I agree. Yeah, I agree. I think education's key, and I think identity. We really just need to let people know what we do and how we do it and why we do it. And by pushing outcomes out there, we've got to push those outcomes to show people how successful we are with our patients. Are we meeting our MCIDs? What do we do that we all know we do it effective, but now we got to show everybody else that we do it.
Keep showing it.
Yeah.
The other thing is the value of what we do individually. When we look at some of the patients that come in, there's patients that have a certain value for a chiropractic adjustment. Like, man, they wouldn't pay $30 across the street, but then they pay another guy $1,000 to do a program or something like that. It's perception, and it's amazing how I think in the past we got caught up in we're cheaper than other professions, and I actually don't argue that point at all, because there's a work comp study, $300 to see a chiropractor versus $5,000 for medical treatment, right? But who has a $300 work comp patient come in, right? I mean, it's more than that. So it's getting the value of, you can do things with your grandkids. You can go to the ball games and sit down. You can, go up and down the stairs to your basement, or up to the attic that you didn't used to be able to do. And as crazy as it sounds, taking the time to make that important to the patient and give them the value of it increases the value of what you do, no matter what it is. And if you're always going to be valuable to individual people, it really doesn't matter what's going on in the system. You're going to still be able to, thrive.
I think that's really important. Is like, I don't say to my patients when I'm sitting down and taking their history and doing the consult, I don't say what's wrong with you, and we always say what's the matter, what matters to you, more importantly, and start having that conversation from there, and then reverse engineering what I need to do in my examination and their awareness and the things that we can do to help them. And Jeff, I know with you, I've had good and bad experiences, hiring associates. And when I saw you at Parker, a couple of weeks ago, I think you had, like 10 or 20 staff members with you. And, Jay, you've got lots of employees, right? Yeah. And, most of us may have 1 or 2 or 3 or 4 or 5 employees. these guys have a lot of employees, right? So tell us a little bit, share, what's your advice about hiring another DC?
So start with the hiring another DC. I think in chiropractic, that's something that always goes bad, is associate, existing doctor relationships. Everybody ends up upset at the end of it, it seems like. What I always did was I looked at what was it I was looking for, and sometimes it's more time, sometimes it is more income, sharing the cost of your expenses and things like that. And then I would set up a contract that I would work for myself. Like if I was in their shoes, would I want to work for that? And one of my doctor's contracts, I absolutely would have flipped places with him in a second if I had the opportunity, just because I'm a go-getter, and it was set up, it was so incentive laden that could have made just a very, very good salary on it and had very little responsibility, because if the overhead's not met, it's not his issue, that's my issue. Mm-hmm. And so I think that's always important, is putting yourself in the other person's shoes and saying, would you work for this?
Yeah.
I really like that. I think it's the core of human-centered design, right? It's empathy, and I think that's a great point. For me, it's always about fit, and when it comes to fit, there's two things that really come to mind, which is core values. We are very clear about our mission statement. We're very clear about our core values, who we are, what we believe, how we behave. And when I used to hire doctors, I was like, oh, can you do instrument assisted? Can you adjust? Do you know F&D? Like, that's how I used to hire doctors, and that's why some of those relationships didn't end up so well. But after a while, I started to understand the importance of core values and alignment of core values, which then drives a good cultural fit. So when I interview now, like some of the questions I might ask are, so did you play sports or a musical instrument? Like, who was your favorite coach, or who was your favorite teacher? And tell me why. Tell me a time when your coach made you do something that you didn't want to do, but you did it anyway. And how did that make you feel? Like, I am literally digging as deep as I can dig about who that person is in front of me, not what they can do, but who they are. And I will tell you, it has made a tremendous difference in my business.
Yeah. With the questions, some of my staff have been in on my interviews, and they're like, "Oh man, you asked some really crazy ones on that. If you're on an airplane, you can't communicate with anybody. What would you tell?" It's
That's great.
You come up with all these things. Why are manhole covers round? Just all those types of questions, and it's neat to also see if they can think. Yes. And then there's some mystique afterwards.
So how do you manage your staff?
I don't really manage. I actually hate that word.
Okay, what do you do?
I try and lead to the best of my ability. Okay. And I think, if anybody's ever read the book Drive by Dan Pink, you understand what intrinsic motivation is all about. It's all about autonomy, mastery, and purpose. So I think we're very clear about our purpose in our organization. We make that clear from the very beginning, even in the interview process, as I said. Mastery, when people come into our organization, we work really, really hard and spend a lot of time and a lot of money on training them. Nice. And then on the autonomy, did I say mastery? That was for mastery. But on the autonomy piece, it's like once we train them up, we let them do their jobs. I have people on my team, I literally never tell them what to do. I'm like, we have our weekly meetings, and they're telling me what's going on, and I'm really there to support them. That's my role as a leader. I'm a collaborative leader, and I'm there to support them. I hire great, talented people, and we just let them go. And it's remarkable. It's like you said, like I'm here, and people are doing whatever they're doing back at home, and things are great, and I'm hanging out with you guys, which is super cool.
But there is a lot of behind-the-scenes work that you do to get it to that point.
Oh, no doubt. That's a really good point. I'm glad you said that. So yes, so it's not like I just don't do anything. Right. I have literally every week I meet with all my direct reports, and they give me status reports, and we've got data running across our desks every single day on where the business is. And so it's not like, I'm just kind of sitting here hanging out. That's a very good point. I'm glad you brought that up, because there's a lot of infrastructure that goes into being able to get to a point where we can do what we do.
Because a lot of times, I've got an office, manager, leader. I'll have to change that going back. But there's things that she doesn't do the way I want done, and so I sit there and I go through and say, okay, why did you do this? Why did you do this? Okay, I see where you're thinking. Here's what I want to have happen if we could replay this. Good. And it seems like you're wasting time going over this stuff. But if you don't do it, it's going to happen again. And we have weekly team meetings, and I wish I didn't have to go to weekly team meetings, but they run the weekly team meetings, but if there's low energy, hey, everybody stand up, let's do some burpees or something or whatever, and get the blood going. If they start to just, seems like somebody's drifting off, hey, we need to refocus because patients are important. Why do you need to know about this new patient that came in and has this condition? Because you might have to talk with them a little bit.
Okay.
And if the patient, we're really big on, we've got a travel card. It's funny how things go in cycles too. We had a travel card, we get rid of travel cards, but now with electronic, you don't have anything written down. So this little notes, like she's got 3 dogs and she loves her cat more than the dogs. Where do you put that when you don't have a paper chart?
Yeah.
So we have a little thing that goes around, but it has all their goals. And so that way any team member can look at Susie and say, Susie, how are you doing with walking the dog down the street? And they all think that we've got some type of ESP.
The goal.
But it's, and then we communicate through the computers in the office too, where if we say something in one room, they walk over to the other side of the clinic and somebody says, okay, I'm going to get you this and this done. And they're like, how'd you know that?
Office communication.
Yeah.
It's a good thing. So Tom, Jeff, you said something about replay. And Tom, you have probably been in practice more than us. I think I'm pretty close to you as well. We're the elders. And but if you could start over, right? If you really could start over, like what would you do different knowing what you know today? What would you share?
I'm not sure I would do really anything different. From a chiropractic standpoint, I think I got lucky, honestly, with what I did. But I think what we need to do, I think sometimes we're so afraid to communicate with other health professions or other chiropractors in our town. Yeah. I see so many times, and that's maybe what I would have done differently, is form better relationships with the other chiropractors in town. I knew them all, I talked to them, but there wasn't that sense, 30 years ago, referring back and forth.
Yeah, not sharing.
Yeah, not sharing. And, I think when you can get, we all kind of, I think chiropractic have the same mission and vision and values. We want to help patients, we want to take care of patients, and that's really a good alignment. And when you get that alignment and help each other, that's probably what I would have done more so.
You have any thoughts on that?
Yeah, I would have done a fair amount differently. I've made a lot of mistakes over the years.
What was your biggest mistake?
And I don't think there's one biggest mistake. I think there's just too many. But I think first I would have read, the first book I would have ever read would have been a book called The Culture Blueprint by Robbie Richmond. So he worked for Zappos, and Zappos has the legendary culture in the organization. And they were bought by Amazon for I don't know how much money. But I would have read that book, and then I would have done a much better job hiring people. The lessons that I learned later in my career have helped me now, but if I knew that going in, I would have done a much better job of bringing in the right kind of talent and doing a much better job of creating the culture that I wanted rather than living in the culture that I created.
I would have moved faster if I could go back. I would have done things a lot quicker because the mistakes, I would have made the mistakes quicker. Because then you learn from it, you can move on. I'm a perfectionist type, and there's a lot of times that I would hesitate, I'd analyze stuff, and I just, looking back, would have done it quicker, and then just accept the results and move forward, because there's a lot of stuff that you can get back, but you can't get your time back.
So what were some of your biggest breakthroughs?
I think probably my biggest breakthrough was early when I started working with industry, and we put clinics in industry. I don't think at that time there was many chiropractors doing that, so I think that got some recognition, and then I got very busy based on that. So I think that was my biggest breakthrough, was really just going to industry. When everybody said, "Oh, you're not gonna get anywhere," they think chiropractors overutilized. You're not going to break into that door and treat workers' compensation, and I did. And again, it was just, it wasn't a magic recipe. It was just communicating, forming relationships, and letting people know what you do, and let them know the outcomes you can get. And then, I tracked outcomes from 1990 on. I was tracking and giving those outcomes out. So I think that really helped, and that was probably the biggest breakthrough I had. And then, comp has just been something for me that's always been easy. It was just simple.
So, we have a rare opportunity having you here, to be able to open up the white coat a little bit and share some of the history about the ACRB, the American Chiropractic Rehab Board. What are some of your early thoughts of those?
Yeah, it's Well, Kim Christensen really, started everything.
Yeah, I'm not sure everybody even knows who
Yeah,
Kim is,
It's
right?
kind of evolved to where he's not around as much anymore.
Yeah.
But, way back, gosh, and George.
He did retire, by the way. I
Did he?
tried to get him
Yeah.
here this weekend.
Yeah. I think it was, and this is really council related, but George, was it Washington or Philadelphia when we took over the council?
Over
Just-
Washington.
Washington.
Planned that view
Yeah.
of the
Like, that was like-
physiological
It
therapeutic.
was like
I was
94
there.
or something, wasn't it? 94, 90?
Oh my God.
We went to Nashville in 94, remember we were all out there, and then in 95 we had the vote and took over.
Yeah.
And then I unified Craig Levinson, Kim Christensen, and Gary Ierna, and you know the rest. We formed the board. Terry was our first president, then I ran it, then you ran it, and so on and so forth.
I asked George this question because I told him earlier that he couldn't keep his mouth shut for the whole weekend. So I really baited him there and got him to
You get
talk.
free
So,
drinks.
yeah, exactly.
And I'm gonna ask this-
We'll do that next time.
Exactly. So yeah, and he's right. And, we were even asking the guys that were big players in the beginning were Craig was there and Kim was there and Gary Ierna. And I didn't even ask about Gary. I don't even know what Gary's doing these days. But I haven't talked to him in years. But those are kind of the three big programs. And then as we formed the board, it was kind of that in the early mid-90s. It was the whole thing between high-tech and low-tech rehab. You had a group over here doing MedX,
Yeah.
then you had another group over here, jumping on gym balls, and that was the big argument. Was high-tech versus low-tech. Then we kind of got through that, and then kind of the Yada era came in, where we were doing a lot of Yada work. So there's been a lot of change throughout our profession, and I think the council has done a great job at keeping up with that. The board, the difficulty we face is getting a test that's representative of what is important to be a diplomate, and doing field studies, and there's just a lot of work that goes behind that. And it's I think we've done a good job of keeping up with that. At testing, we've refined our testing. We sometimes look at it and say, geez, when we tested back in the 90s and what we do now is wildly different. And I think we've really refined and done a great job doing that. I know there's a little push right now from the ACA about having systems in place. So you do cut scores for all your tests. You have processes. And thanks to Dave Juring, I don't think Dave's here, but thanks to Dave, we've done that for many, many, many years. So we've adhered to the NCCA standards for a very long period of time. We decided not to join that group because it was about $40,000 to $50,000 to do so, and we didn't think that was a good use of everyone's money. To do
What
it.
is that group? Share with
It's
us.
it's a national certifying agency. So what they do is they make sure that your program is living up to has a standard. So it can't be just that we're the judge, juror, and executioner. We have to have a standard. How do we write the test? How do we score the test? How do we develop scores? How do we tell the participants when their exam is? How do they prepare for it? All those things are standards for. How do we recertify? Why do we recertify the way we do? Our main job, I think I told you the other day, and I think it was a surprise to you to a degree, was the main job of the board is really to certify at a minimal competency to protect the public. So when somebody comes up and they see that someone's a diplomate, they know that there's a minimum competency that they had to pass to be a diplomate. And we don't test to see how smart someone is. We test to say that here's the bar, you gotta get above that bar. So that's our main job, is to protect the public. So they know that when they come to a diplomate, there's a certain expectation. So that's happened. We've trademarked, we've done all the things we need to do to make sure that the board can continue to exist when we're not here. Yeah.
That's good. So what are some of the future action steps for rehab practitioners? What do you think, Jeff? Future action steps.
Let's see. I was going to go back to breakthroughs.
No, you can go ahead and share that. What was your breakthrough?
No, I'd say, as crazy as it sounds, written goals. It's amazing how much of a difference that made after I started writing stuff down and focusing on that. But
Get clear on what you want.
So what was your question?
Well, what are some of the future steps, for rehab chiropractors?
Well, in my opinion, it would always be looking out for what's coming up on the horizon. Looking at your threats to what you do. If you already have a practice and you're successful, what can take that away? And then just making sure that if it's a change in reimbursement, if it's a change in the hospital's eating up everybody else and taking away your referral sources, whatever it is, being able to assess what's out there as a threat and then be able to proactively solve that before it even comes up. that's one of the things that I do a lot of, is I see things that that are potential problems, and then I solve them before they ever even come to the surface.
What do you think your biggest?
So I would say,
What is the biggest threat to you, Jeff?
to Jeff,
Yeah.
To me?
Yeah. What is the biggest threat you think for the profession?
To the profession or to me personally?
Profession.
To the profession? I would say the biggest thing is losing the identity, because the PTs, the APTA is very strongly pushing to eliminate chiropractic as a profession. And I mean, they might not even say that out loud, but they are very unified with their message. And the older PTs, they don't like the APTA either. I didn't mean to get into this, but I mean, that is something, if you're going to ask me about.
yeah.
They, if they want to be the musculoskeletal people and the only people that do musculoskeletal, and so that would be a huge threat. Is that if the healthcare system is just one main system in the United States instead of all these little clinics and things that we had in the past, then if you're not at the table and not able to provide it, then that would be a problem.
So I have a slightly different perspective on that. I think you're right, because that kind of ties to unity in terms of you just don't want to be these individual doctors out there that are, we're kind of struggling by ourselves, lone wolves, so to speak. My experience has been a little bit different, at least with the PTs. We're dealing with a reimbursement issue right now on the East Coast, and we're working with PTs, we're working with APTA and the local PT associations to get these payers to do what they frequently need to do. So I think I don't disagree that they'd probably be a lot happier if we were gone, but we're here to stay.
Mm-hmm.
So how do we find ways to work together where we can actually fight the common enemy, which is the carriers? That's just my personal opinion. But I did want to get back to your other question, which was what's important for rehab chiropractors moving forward. And I would say there's really three things. I would say education, which you guys are doing right now, just continuing to learn. But I think that's the internal piece, but then it's external education. Like, I think you guys do phenomenal work, and the public probably doesn't know enough about how damn good you are. So I think external education is also important. The second piece is data. Tom mentioned he's been collecting his outcomes since the 90s. That moves the needle. So anything that you can do, either individually or collectively, going to your electronic health records company and being like, hey, how do we aggregate our data over time? That's what we did. We went to Genesis and we said, we want to aggregate our data so we understand our outcomes, which providers provide the best interventions for any given condition. Can you rebuild this system? And they said, great idea, yes. So whether it's ChiroTouch or Genesis or Eclipse or whoever, go to your providers and say, as a profession, and you as a vendor will benefit tremendously as we can aggregate our data over time. So that's the second piece, data. So education, data, and then the third thing is advocacy. It's not enough for 1/10 of 1% of the population to be fighting these battles. And I'm not saying it's necessarily the people in this room, but we need a lot larger of an army. We go to NCLC and there's not nearly enough doctors there. At our state legislative days, we don't have enough doctors there. We need aggregate EOBs so that we can show that Care First is paying us incorrectly, inappropriately. And we got doctors kind of sit on their butts. And then they complain about the situation that they're in. So, advocacy is important. I will tell you one last thing as it relates to this, and then I'll shut up for this question at least. You know what? I've spent, tens of thousands of man hours working for this profession, and it's a blessing. Because it's like anything in life, you get out of life what you put into it. And I have made the closest friends on the planet because of the work that we do together. When you go to battle with your colleagues and your friends, you build a bond that is there for a lifetime. And I'm blessed because of the work that I do, because of these relationships that I've built. So yeah, it's hard work, yeah, it's time out of your practice and your family, but at the end of the day, I promise you, if you put the effort in, you'll get so much more out of it.
Okay. Something else, kind of following up, is making yourself valuable. And again, that's part of this whole education of people. But with the PTs, that was something that the PTs never thought that there would ever be a lack of opportunity for them. But in the last year with the system. I mean, basically, healthcare has gone to where they want to be able to have a computer diagnose somebody. You run some blood tests, have a computer analyze it, and spit out what drug they need to take. I mean, that's what we're up against. I mean, that's what I've seen anyway. And so when you're looking at people, people still need physical touch, they need physical hands-on. I mean, people need to interact with people. And as long as, I mean, when you look at rehab opportunities, that's a huge opportunity right there. But in the last couple of years, I've had PTs and PTAs come and ask me for work. Even just last week, the hospital consolidated things because of the way insurance is paying for something. And so there's a whole bunch of PTs that are now going to PRN, which means that they don't get any benefits. They just get paid when they're working. And so it's a cost savings measure. And that's across the board. You have to make, if you want to be paid well, you have to be able to defend why you're valuable to people.
One piece that I probably should bring up that I kind of thought of as you were talking about, early on in my career too, when I was collecting outcomes, and I still did it for 30 years, is I developed a report card for my top referrals that would say, how many conditions I broke into cervical, thoracic, lumbar, how many conditions they sent to me, what was my outcomes, how many visits per episode, what was the cost, what was the outcome, what was our MCID, our clinical differences we made, and I would give those to those docs and explain to them, here's what I did. And then I continued to get referrals. It wasn't hard to do. Early on, it was an Excel spreadsheet that I extracted on. But if you could do something like that, I think that's a value to our profession as well, and I think that's a value in your community, and that educates those doctors for you. I think it's just a little piece that, it takes extra time, but it's really definitely worth it.
It's a brilliant tip.
Yeah.
That's brilliant. I love that.
And you mentioned about where we're going, and I think I've made it pretty clear. I think we need to diversify a little bit. I do more than just the musculoskeletal. Let's do a little bit more, understand a little bit more. It's not that hard to get that learning curve up, and then that positions you to do many other things. So.